Thank you very much for the introduction. Thank you very much for the invitation, George. It's a pleasure to be here in Athens again. I don't want to promote anything. That should be a scientific talk. I just want to report, and you can make your own mind up in the end what you think about the technology. Today it will be about cardiac stiffness evaluation by shear wave elastography, and this is indeed a little bit like still a look into the future in a crystal ball, and because this is not yet available clinically. We are doing the first steps in this technology, and we are gathering experience, and I would like to explain you a little bit what that is, and I would like to share our first experience in that field. Let's start with high frame rate echocardiography, because this is the basis for that all. And what is that? When you think of the way echocardiography works, you're sending out a focused ultrasound beam, and this focused beam is then transmitted to the tissue and reflected by the tissue. And that takes a certain time, depending on the sound velocity, depending on the depth of the image. Usually it takes around 200 microseconds for such an impulse to return to the probe if it is reflected at the very bottom of the image sector. That means we can do around 5,000 impulses per second, or 5,000 of these beams per second. And now we can think about how to use these beams. We can use the beams to build up an image, and we can do that like it is normally done with like 180 to 200 lines. So we send the beams in different direction, wait for the response, send the next one. That means 5,000 lines per second, and then we need like 36 milliseconds for one frame, and we end up with a frame rate of something around 28, 30 frames per second. That is how physics tells us how things work. If we want to increase frame rate, we cannot change physics, so we have to think about tricks how to do that. So the normal thing, one line is one impulse, 28 frames per second. We can think about doing that a little bit different by taking advantage of the fact that we have to focus to receive good echo signals. And we can focus a little bit less on the sending side, so we send a little bit of broader pulse. So it's worth 2 lines, but we are listening, we are receiving in a very focused way. So we can receive 2 lines with 1 impulse. In that way, we can use 1 impulse, a broad line, to, that's a bit slippery here, that's better. We can use 2 lines for, 1 impulse for 2 lines, so that would increase our frame rate already. It doubles it, and this is actually what is done by most ultrasound machines nowadays. You know, when you start up your machine, you usually scan in the range of 50 to 70 frames per second. But you can push this idea further, and by not focusing anymore at all when you send out the ultrasound, so you make a big bang and you send the ultrasound in all directions at once, and then you just listen selectively in different directions. And when you do it like this, then it's actually 1 impulse that you need for an entire image. And in that way, you can use all the 5,000 impulses that are possible physically. You can use them for making images, so you end up with 5,000 frames per second. Sounds a bit like magic, but it's possible. Nowadays, we have computers that are fast enough to process such an amount of data, and we have the echo probes that are able to do this selective listening, so they can send all the signals from all the different crystals immediately to the ultrasound machine. It can be stored there and post-processed in a way that you focus selectively. This is an ultrasound machine that has been built by our engineers in the lab. It doesn't really look like an ultrasound machine, but I can promise you it is one. And it can do 5,000 frames per second. It produces an enormous amount of data. It's like 1.5 DVD per acquisition, so for 2 seconds. And in the beginning, we were processing overnight for 1 acquisition, but in the meantime, we are almost to real time. And The trade-off is, of course, that the energy that you can use for one image is rather low. And the image quality is not that good because the energy that you usually use for one line is now used for an entire image. So it's a 200th of the energy that you use for one image, and the signal-to-noise ratio is not so good. So in the end, we are ending up with compounding a few images to get a little bit better signal-to-noise ratio. So we are using 3 or 6 images, put them together to make one image, so which reduces our frame rate back to around 1,000 frames per second, but this is still quite a bit. And then you can start doing things with that. And people have looked into what can be done. And one I just want to mention briefly is blood flow imaging that has been proposed by a Norwegian group from Trondheim, and they process these data in a way that they do speckle tracking on the erythrocytes. The erythrocytes, they are very small and they move pretty fast, but with 1,000 frames per second, it's possible to filter the motion of the erythrocytes out and show them on the echo image. And this is a neonatal image that shows a VSD, actually. Yeah.
Tell the audience that οι εικόνες που βλέπετε πράσινες εδώ δεν είναι οι ίδιες εικόνες που βλέπεις στον υπολογιστή, που είναι κανονικό χρώμα, κόκκινο, μπλε και ο χρωματισμός είναι σωστός στον υπολογιστή. Αυτό που βλέπουμε δεν είναι ο σωστός χρωματισμός και απλώς για αυτούς που βλέπουν τις εικόνες να μην... παρόλα αυτά. I'm just explaining that the images we see, the colors we see here are not the same as in your computer, because I have...
I can turn the computer around and you come closer and we can watch together.
They said that they are still impressive, so we can move on.
And this is by showing the flow lines where the blood flows. And there's a neonatal shunt in the VSD, and this is the flow inside the unborn child. This is, in the meantime, available commercially. So you can have that from GE if you want to buy it with a pediatric probe. You can do these things. They use like 800 frames per second for that. This is from a French group. They go even further. They do that even 3D, and they look at the myocardium. What you see here is a very strongly magnified image of the myocardium, and that shows the blood flow in the myocardial blood vessels. You see how here in diastole they light up in blue, and in systole in red. So this is also possible, and you can even do flow measurements in these vessels. But this is just a sidekick. What I want to talk about today, and this was the task that I got from George, is to say something about elastography or shear wave imaging. Shear waves are a certain type of waves where the amplitude of the wave is perpendicular to the propagation direction. It's a little bit like when you drop a stone in water, you get ripples, and these ripples go up and down while the wave propagates sidewards. So this is the definition of a shear wave. And you can have such shear waves also in the myocardium, and you can excite them either with a strong ultrasound impulse. You can put a very focused strong ultrasound pulse, and then you will move the myocardium a little bit, and it generates a shear wave that travels through the myocardium away from that point of excitation. Or you can have such shear waves also when certain things happen in the myocardium. For example, if a valve closes, if the aortic valve closes, or if the mitral valve closes, this closing moment moves the myocardium a little bit and leads to a shivering in the myocardium that goes down from the base towards the apex. And that's also a shear wave. And you can use now and that's why we're talking about the high frame rate imaging. They move rather fast, so you need fast ultrasound to capture that. And you need this high frame rate imaging to visualize these waves, and then you can measure their propagation velocity. And when you do so, you have it, because the propagation velocity is related and is, with this physical formula, directly related to stiffness. So we have a direct way of measuring non-invasively a physical property of the myocardium, which is new, which was not possible before. And this physical relation counts. The other one is just density, that's something we know, so we can directly convert that. This is one of the early experiments from a French group from Paris. They tried that with induced shear waves on an open chest model, and you see here the stiffness changes of the myocardium during the cardiac cycle measured with this technique. In our lab, we use the natural shear waves, as we call them, so the shear waves that occur after the valve closures. And you see here again our ultrasound machine and our engineers in the lab having fun. So that's the high frame rate scanner here. And we're playing around with this technique. And this is how it looks like in a real human heart. You see here the acceleration of the septum towards the transducer. So the up and down acceleration color-coded. This is an image with 1,500 frames per second. And you can imagine that something is traveling there from the base to the apex, but it's a bit difficult to see. So what is easier is when you put an M mode there, and then you draw this M mode, and then it's much clearer that you have really a wave that travels from the base towards the apex. And when we measure the slope of this wave, we can determine how fast the wave propagation speed is. We have validated that in a very classical way. So this is an agar phantom, self-made, and so you have to press it and you measure the deformation. And we also need the density. This is Archimedes, an ancient Greek method of measuring density, putting it in water and seeing how much flows over. And then we did some experiments with this agar phantom. So we were dropping a steel ball basically here in this little paper tube on the phantom, and then it generated a wave from here that travels through the phantom, and that's the M mode that you generate with this, and you can measure the slope and calculate the stiffness, and the calculated stiffness and the expected stiffness from our measurements of the phantom itself, they corresponded very well with only a few percent of error. So that seems to hold. So let's now talk about human hearts and about physiology and pathophysiology. When we think about the function of the ventricle, you all know these pressure volume loops. But you could also look locally at the myocardium, and instead of pressure and volume, you look at stress and strain. That gives the same loop just for the local myocardium. And when you look at this loop, you have these two moments when the aortic valve closes and when the mitral valve closes. And this is at two moments when we could say something about the end systolic stress-strain relation. So this is sort of related to contractility. And we can talk about this end diastolic stress-strain relation. And this is the diastolic property of the myocardium. This is the stiffness of the myocardium. And actually this is a curve, it's not linear, so we have to know where we are on that curve. So we are talking about an operating stiffness. That's the stiffness at that point in the curve. That's the tangent to the slope, or the tangent to the curve. This is true for a certain filling pressure. And when then the myocardium gets stiffer for a certain reason, for pathology, or because of pathology, then we have maybe a steeper curve, and then we have another operating stiffness. We have a stiffer myocardium. Again, this is true for a certain filling pressure. If the filling pressure increases, we are at another point at the curve, so we can get also the higher stiffness on the previous curve here. So this and this stiffness is the same. So we need to know something about the filling pressure, or at least we have to keep in mind that if we measure enhanced stiffness, that could be either because of elevated filling pressures or of elevated stiffness of the tissue. So we did some animal experiments to try it out. And this is from pigs, where we changed preload, which is basically moving up and down on that blue curve. Afterload, that moves the entire loop a bit, but in the end, the anti-diastolic point is also moving up and down the curve. Preload increase, again, on the curve, and then changing the curve itself by changing the stiffness of the myocardium by inducing ischemia reperfusion injury, which makes the myocardium immediately a bit stiffer. And here you see the end-diastolic pressures of the ventricle that were measured under these conditions, and you see they follow the interventions as you would expect it. And these are the stiffness measurements that we have. So if you reduce the preload, the stiffness goes down. If you increase the preload or the afterload, the stiffness goes up. So this is moving on the curve. And if you change the curve itself, so if you make the myocardium as such stiffer, then you also get elevated and strongly elevated values. So it seems to work. The question is, does it also hold true in the clinics? This is very early work from a Japanese guy in children, just proof of principle, induced shear waves in children's hearts, and he just showed that it is possible to do that. The first work that looked really into pathology was again from this French group from Paris, from Villemain, and they measured also with induced shear waves normal volunteers, and what you see here is that the stiffness increases with age. This is something we always expected from our experience from diastolic measurements, for example, but we never had it like this, that we really had measurements of the stiffness of the myocardium itself. So you see myocardium gets stiffer with age. The interesting thing is that they also looked into patients with hypertrophic cardiomyopathy. And the interesting thing is that these patients were had way higher stiffness measurements than the normal volunteers. So it's a very strong signal in pathology. So the stiffness seems to be something very sensitive to pathology. And that makes hope, at least, that this is something that we could use in the future in the clinic. Here you see two of our PhD students, an engineer and a doctor, preparing the room for a patient examination. In the meantime, we don't use this junky machine anymore. We have a commercial platform that is modified in a way that it can do these things, which also improves the image quality, because a commercial platform is always better in signal processing than a self-made machine. And this is how it looks in patients. We get these M-modes, and we see here these shear waves occurring after mitral valve closure and after aortic valve closure, and then when you magnify that and measure the slope, you can say something about stiffness. It's a noisy business, but it's okay-ish, so the intra-observer reproducibility is reasonable. So we can measure, let's say, in a range of 0.5 to 1 meter per second accuracy what we are seeing. And this is our first experience in Leuven, where we looked into healthy volunteers as well, just by age range, and you see we have similar findings. This is now not kilopascals, so a measure of stiffness. This is now the shear wave velocity as such. And we see also here that the stiffness increases with age. A colleague of mine, a PhD student of our lab, has looked into that a bit more in detail in children and in adults, and you see here that we have this change of stiffness of the myocardium, and we see that from 0 to 80, so all during the entire lifetime of a patient or of a volunteer, and we see a particular increase here in the very early time, in the first years. This is the time when the heart is still growing. So there's a little sidekick to it, because this formula that I showed you is only true if you have an unlimited big piece of meat that you're measuring. But the heart is limited in thickness, so it has a certain thickness. And this thickness produces what physicists call a guided wave, and these guided waves are a bit slower than the normal velocity that you would expect. So if you have a thin wall, you might measure lower values. And that's probably why we have this onset of this slope there, which is a bit steeper than the rest. How does it look in disease? One of our first tests was in patients with amyloidosis. And you see also here that the shear waves after mitral valve closure and after aortic valve closure have much higher values in amyloidosis patients than in controls. A study that has been performed during the COVID pandemic or shortly after, when we got some children with COVID-related myocarditis. You see when they come into the hospital with symptoms in the acute phase, they have also elevated stiffness of the myocardium, and that gets better during the following months, and it takes around 6 months to recover. And the shear wave measurement was one of the last measurements that normalized in this period, and only after 6 months it was so close to what we measure in normal controls that it was not significantly different anymore. This is a study in hypertensive patients, and we have an early stage of hypertensive heart disease when we have concentric remodeling. So that means that the myocardium basically gets thicker to adapt to the pressure, but it has no structural changes. And then at a later stage you also get diffuse fibrosis in the myocardium, so you get a stiffer myocardium, and you see this difference here. In concentric remodeling patients we had slightly elevated values but no big difference, and in concentric hypertrophy patients we had significantly increased stiffness measurements. So obviously it's something this is pretty sensitive to fibrosis and scar. And we looked into different clinical scenarios. This is a study in 47 heart transplant patients. And they come regularly to our clinic for checkups, and they get a right heart catheterization to see how they develop, how the filling pressures are. So we have invasive data of the filling pressures, and we have also MRI measurements in these patients from T1 mapping that says something about diffuse fibrosis. And you see here the correlation of the T1 mapping, which is considered a sort of a gold standard nowadays for diffuse fibrosis measurements in patients, with the wedge pressure on the left side, so filling pressures measured invasively, and with the shear wave velocities on the right side. In both cases we see a reasonable correlation, but actually the correlation for the shear waves is better. So we have a non-invasive measurement that correlates better with what we find in MRI than an invasive measurement. So also here, maybe that's something we can use in the future clinically to replace even invasive procedures. That's a bit complicated, but this is about CRT patients, cardiac resynchronization therapy patients, and one big issue there is scar in the septum. That's particularly bad, and that's particularly difficult to detect, because there is basically nothing except of MRI that you can use to see a scar in the septum of a left bundle branch block patient. You cannot do that by scintigraphy because it always has a low uptake in the septum, so it's difficult to distinguish scar from the left bundle branch block artifacts. You cannot use strain or postsystolic shortening or something because these curves are almost looking the same. So it would be good to have some non-invasive, cheap imaging method that you could use. And we tried our method because it works very well in the septum. And you see here controls and patients with a left bundle branch block with and without scar. And we saw that it is a little bit elevated stiffness in patients with left bundle branch block. That was also significantly elevated, but okayish, slightly elevated on the borderline, in a borderline region. And patients that had a left bundle branch block and a scar in the septum had clearly highly significantly elevated values. So also here maybe it's something that we can use clinically. And as I mentioned in the beginning, it's very close to passive tissue properties. We are basically measuring stiffness of the myocardium, so it's more or less logic that we try to use that for diastolic function. And this is from non-invasive comparisons with normal echo parameters. If we do diastolic function grading by the standard guideline approach and shear waves, that correlates quite well. Also, it correlates with EE prime. But we thought we should try that with invasive measurements. So we did catheter measurements of patients that had, for one or the other reason, a catheter in the left ventricle, where we could get hold of end diastolic pressures and mean diastolic pressures. And we tried to correlate that with classical echo parameters, and we all know there is a correlation, but the correlation of a single echo parameter is never perfect. And with the shear waves, at least for the end diastolic pressure, there was a reasonable correlation, and it was a rather good sensitivity and specificity to distinguish elevated filling pressures from non-elevated filling pressures. That's still under revision. It's not yet accepted, but we hope that we'll get through soon. And the last study I would like to show is in Fontan patients. Also, these patients experience diffuse fibrosis, so stiffening of the ventricle. And there it's particularly difficult to make measurements in a clinical routine on a normal basis. And clinically, they appear as what is called failing Fontan, so they become symptomatic. And we see stiffness differences between patients who are doing well and those with a failing Fontan. And there is a way of measuring pressures in the vena cava, which correspond quite well to the filling pressures in the ventricle. And also here we found reasonable correlation. So, ladies and gentlemen, in summary, there is a concept of high frame rate echocardiography that is technically feasible nowadays, and only depending on image depth we can produce frame rates up to 5,000 frames per second in a technically decent way. We can use it, for example, for shear wave imaging, which allows the direct measurement of a myocardial property, of the myocardial stiffness. And this, I think, is a quite promising, or could be a promising clinical measurement. We have to keep in mind, however, that these measurements of stiffness reflect both changes in myocardial properties and the filling pressures of the myocardium. We are not yet there that we can use that clinically. We are working on the clinical implementation, and maybe it will be available commercially in not too long time. But there are still some hurdles to be overcome. But I think it's a promising technique. Thank you very much for your attention. 2 words if you're interested, sorry, I forgot that. If you are interested in reading something about this, we had a review paper recently published about the technique. It's rather comprehensive. You will know everything about what is known at the moment. And I have to thank the entire research group, because this is not a work of one person or of a few doctors that do something. You need a big group of engineers and a group of doctors working together. So thanks to all of them.
Well, Jens Uwe, fantastic. That opens a new chapter in echocardiography, really, high frame rate. I'm sure that this talk will generate many, many questions. I see already George firing up. But let me just clarify to understand. So you use the shear test, shear waves as a surrogate of stiffness.
Right.
So it is meters per second versus kilopascals. What's the relation between the two?
That is the formula which I showed in the very beginning. It's the square root of stiffness divided by the density.
Okay. Which is quite interesting. And before giving the word to George, if the myocardium is itself healthy, no scar, nothing, and you have a left branch block, let's say, does this affect the propagation of the wave, obviously?
That depends on when you measure. And that's one of the limitations of the natural shear waves, that we measure only, or we can only measure when the mitral valve closes. And I was always talking very suggestively now about end-diastolic stiffness, which is actually not really true, because it's a little bit after end diastole. It's a few milliseconds after the mitral valve has closed. So there's already, we are on this rising part of the pressure curve in the ventricle, so the stiffness is already getting higher. But there's still a very good correlation with the end diastolic stiffness. If you measure with a push pulse, so if you induce the shear wave, then you can do whatever you want and whenever you want. Then maybe you would go to mid-diastole before A wave, before atrial contraction, and you would have really the pure myocardial property. So at the moment of the mitral valve closure, it's a little bit a mixture of myocardial properties and hemodynamics.
George.
Well, needless to say that, well, it was a fantastic contribution to, as Petro said, to a new era which is coming in front of us. Is there any relationship between the thickness of the septum, which is considered for measurement? Is there a limitation? You need some millimeters of thickness, at least 5, 6, 7?
No, the thickness of the myocardium is not that critical, because as long as, I mean, you see they measure erythrocytes. So as long as you get a reflection from there and you can detect this, it's fine. What is the bigger problem is that we are currently doing that from the parasternal view, and we are measuring mainly in the septum, assuming that the septum is sort of representative for the myocardium of the entire ventricle. We have a bit more technical difficulties going deeper, like posterior wall, and we are struggling with measuring from the apex, because then we are not looking anymore in the amplitude direction of the shear wave, but in the propagation direction. So that delivers different values, and we still have to figure out how that can be done so that we have access to all segments of the ventricle separately. So at the moment it's limited to where we have robust values and reproducible values, that's the septum from a parasternal view.
From the parasternal view, we may also see a part of the RV free wall.
Yes.
Have you
Yes.
any experience on
For
that?
the Fontan patients, for example, I mean, how to define what the septum is in a Fontan patient by definition, that's almost impossible. So there was, part of it was also right ventricular free wall, or what you would normally consider a right ventricular free wall measurements included. That's also possible, yes.
But you don't have any specific experience on real
no,
RV
there's
free wall?
one of the fellows is doing, he's very much into pediatric cardiology, and he's trying that at the moment, but I don't have data yet.
Because it would be of paramount importance in pulmonary hypertension issues and so on. So
but the Fontan patients show actually that it should work.
It should work, yeah. Thank you.
Dr. Professor Economidis, Ignatius.
Thank you for this presentation. It's a new window in the future. Hope it will be implemented in our machines. Can I ask you, do you have any data regarding medication and changes of wave after some kind of medication?
Yeah, it would be fantastic to have that. So the mavacamten or what all these things that come up now. So we are trying to talk to the companies. The problem is that we cannot use retrospective data. So we cannot go back to the archive and take normal echo images for processing. We have to acquire the images prospectively. So we try to get hold of these patients that are now under treatment and try to follow them up. Yeah, not much. We have another study also on the diuretics, where we want to look at the effect of diuretics in decompensated heart failure patients. So we're working on that, but not too much. So the only study where we really could show changes over time was the study with the myocarditis after COVID infection.
Okay.
That showed clearly an effect, but I don't have anything at the moment with medical treatment.
Thank you.
Okay, I think you gave us a lot of food for thoughts, and I'm sure that next time you come, we will have more questions for you. Thank you, Jens, once again for this very nice lecture. Thank you.